Welcome back to LEMD's live educational series. My name is Lauren Nashir. I am the Director of Medical and Pharmacy Operations here. And at LAMD, community and education are at the heart of everything we do. We don't just offer access to cutting edge therapies. We want you to understand them, feel confident in them, and be surrounded by a community of people that are on the same journey toward better health and longevity. Tonight, we're diving into a conversation that so many women in our community have been asking for, the intersection of hormone replacement therapy and GLP-1s. And we brought in exactly the right person to break it down. Dr. Christy Sawicki holds a PhD in molecular and cellular oncology from the George Washington University and completed her postdoctoral fellowship in epigenetics at Columbia University. She has nearly 25 years of experience in genomics, cancer biology, and precision medicine, and she's spent her career at the forefront of personalized health. Beyond the lab, Dr. Christie is certified nutrition and health coach who specializes in helping women over 40 optimize their body composition, hormones, metabolic health, and longevity. She's helping translate complex science into strategies that people can actually use. Dr. Christie, we are so glad to have you here today. Before we get into the science, can you share a little bit about your journey and what drew you towards women's metabolic health and longevity?
Yes, excuse me, absolutely. So it's always been part of my life. I've always been into fitness and health and, went through a career in biology. And then I hit 40 and everything started to change. I wasn't getting the answers. I was going to multiple doctors, just kind of spinning my wheels, but I knew that I could dive into the research and kind of figure things out. So that's, of course, what I did. That's what I do. So I started reading everything I could, understanding metabolism and not just how like strength training and nutrition play in, but also how the molecular pathways intersect and hormones, just learning everything I could. And of course, that just sort of leads you in your life. Things just kind of come and happen as they're supposed to. So during the pandemic, I decided to that's when it was really kind of heavily hitting me. And I got trained in fitness and nutrition, women's health, and started coaching women through the fitness aspect. And then when I started my own peptide journey, I kind of naturally transitioned into being one of the peptide educators online, just explaining this, trying to simplify it a bit and help people understand it. And that blossomed into even more of a coaching business on metabolic health and helping women sort of transition in menopause. So
It's wonderful. It's such a superpower to have people like you that are helping translate this science, and especially these live educational series, and all of you who are in our community who, may understand some of the complex science, but you don't have to make a meaningful impact and to share how things may change your life. So we'll kind of dive into the topic to start. When we think about HRT, which is hormone replacement therapy, and GLP-1s, we kind of treat them as separate conversation. But the research shows some really exciting stuff, how they're intersecting. Can you explain how estrogen and GLP-1 signaling are connected in the body and why treating them separately may be leaving something on the table?
yeah, so a lot of people just think of estrogen as a reproductive hormone, and then we put GLP-1 in the blood sugar appetite regulation category, like they're completely separate. But actually, in the brain and the hypothalamus, they share receptor, like they work in the similar region of the brain, which is the master hunger center. It's actually loaded with GLP-1 receptors and estrogen receptors. So these two signaling pathways are kind of overlapping in that same region of the brain. And when estrogen is present, it's actually priming the neurons that GLP-1 activates. So better hunger suppression, better activity. And estrogen plays a role in our body in the gut, making its own GLP-1. We make GLP-1 naturally. We call the medications GLP-1 receptor agonists because they act similar to what our body produces. So estrogen is essentially an amplifier of that system and a participant in the system. And the reason we are here talking about this really is because there was a Mayo Clinic study published this year they were looking back on data that was collected on people that were using tirzepatide, one of the GLP-1 agonists, and they put them into two groups retrospectively, and they looked at women on HRT with tirzepatide or tirzepatide alone. And they found that women on HRT and tirzepatide had a 35% greater weight loss on that combined treatment. So that is not a small finding. That is our biology at work. And that's what fascinates me and intrigues me to learn more about this because really it's all about restoring that biology as we get older.
Definitely. Weight gain can be kind of one of the more common symptoms reported in postmenopausal women, and just how their body may not be responding to their kind of internal signaling. But let's say a woman was on GLPs and they're kind of in this later stage of life, they may hit a plateau. Can you talk a little bit about that? If someone's taking GLPs and they're not experiencing the weight loss that they would like, and kind of what they can assess around that.
Yeah, I do think that there is a role there. It's an emerging area. There really isn't a lot of direct data saying that but mechanistically, what we can look at is the signaling environment that GLP-1 is going to respond better to when we have an insulin deficiency or chronic insulin resistance, chronic inflammation, even that brain region, that hypothalamic signaling, if that gets dysregulated, then the what GLP-1 is responding to isn't as primed, if you will. Like it's not going to be a optimal signaling environment. So there's this hypothesis that if we have estrogen deficiency, as we do in menopause, that could contribute to reduced GLP-1 receptor sensitivity. And so restoring estrogen could basically maintain that sensitivity and restore that so that we would have better response to treatment. And I like to say, you're spending a good amount of money on these treatments, so you might as well be getting the full advantage of it. And that's what we're seeing when we combine them in a lot of women.
It's really, really interesting. So that study kind of looked at exactly that, where the women who were taking estrogen with their GLPs did see looked like increased weight loss. So it's really interesting. Can you just give a little background of kind of what happens in the woman's body at the menopausal period and postmenopause, like how their hormones change?
Yeah, so a couple of things are happening there. We are seeing well, yeah. So glucose, first of all, estrogen acts on glucose uptake in the muscle, and muscle is the longevity organ, right? So that's what kind of supports our metabolic rate. It supports our insulin sensitivity. So there's a direct role there of of estrogen. It helps the glucose get taken up into the muscle cells. Estrogen also plays a role in visceral fat. So when we have optimal estrogen in women, our fat is stored in our subcutaneous compartment, the hips and the thighs, and where it's, nice and healthy. And once we lose estrogen, it starts to go to the visceral compartment, which is very inflammatory. It's linked to a lot of different diseases, and it creates a whole host of other issues, mainly through that inflammatory signaling. It also, like we just said, it works on the center of the brain, the POMC neurons, which are the hunger center. So it's going to regulate appetite. And any woman that's going through perimenopause knows that she suddenly wants to snack all the time and can't seem to curb her hunger. And that's directly related to estrogen. It also plays a role in the liver, like dumping glucose from the liver. And like I said earlier, it also upregulates the GLP-1 receptors and produces more of your own GLP-1 when you have estrogen. So all these things are biologically going on when estrogen signaling is lost. So it's sort of coming at us from all different directions, if you will.
Yeah, it totally makes sense. This is a whole body treatment, right? Each organ system, or many of them, have the hormone receptors, GLP receptors also sprinkled throughout the body. So it's not just one symptom or one signaling pathway that's going to be affected. You said something really interesting about how estrogen kind of is involved with that muscle signaling of uptake of glucose. It's feeding your muscle cells. Maybe it helps support lean muscle mass. When
Hmm.
people are taking GLP-1s, that's one of the things to watch out for. As you lose weight, you may lose muscle density, which is very important to keep your body metabolically active. So knowing this, can you talk about, how estrogen could that help curb the muscle loss that someone may experience on a GLP?
Yes, absolutely. Because, like you said, we are losing muscle naturally in menopause, in the first 5 to 10 years. So, and bone loss as well. And estrogen is directly playing a role there. So, support if you're, and then if you add a GLP-1 on top of that, which we know we can lose 20 to 40% of the weight can be muscle loss, which is a very bad thing. Like, if you're just looking at the scale weight and not how much of that is actually fat versus muscle, you could be missing a big piece of that puzzle. And it gets much harder to build muscle after menopause. So you definitely want to hold on to everything you can. So tying in estrogen, where it's going to support, it actually supports the muscle stem cells that allow muscle recovery to occur. It restores the insulin sensitivity in the muscle. So all these aspects of estrogen play a role in that muscle loss. So if you're not supporting the hormones while you're on a GLP-1, you could be really setting yourself up for that 20 to 40% muscle loss, which is obviously not a win. We want to avoid that. And then, of course, we want to make sure that we're having adequate protein intake, like 1 gram per pound of body weight, strength training, resistance training, 3 to 4 days a week, ideally, to really preserve that muscle tissue.
God, it's so interesting. Your background's very diverse with the nutrition and kind of health counseling aspect. Could you just give an overview for everyone of kind of understanding why is muscle one of the things that's lost when we want to lose fat? Like, why is the muscle also going? Can we preserve
Yeah.
it? And
Yeah, it's because it's for survival purposes. It's not If the body thinks it's starving, it's going to get rid of the most metabolically expensive tissue, which is muscle. Muscle requires more calories to keep it, to support it. So if you're in a calorie deficit for a prolonged period of time or a very aggressive calorie deficit, the body is just going to get rid of the muscle to basically to survive because it thinks that it doesn't realize that we have grocery stores around the corner and McDonald's and Starbucks. It's thinking that we're still, living in caves and having to fight for our food. So it thinks, if you're starving, then it wants to get rid of anything that isn't essential. And that's why we lose hair too and muscle. So
really interesting, kind of tying this into also the bone density. As women go into menopause, their bone density decreases. How is muscle involved with the bone density loss, if it is? And then if you could talk a little bit about how hormones are impacting that bone density loss.
sure. This is really critical because I think a lot of women, we don't see our bones, so we don't pay attention to it as much. We see the muscle and we can tell that there's muscle loss, but women will lose up to 2 to 3% per year. You can, not everybody, but that can happen after menopause, and it's mainly directly related to estrogen loss. But again, tying that into if you are on a GLP-1 and you're losing weight, that weight loss is also going to reduce the bone loading. So, in other words, if you have muscle and if you have more excess body weight, that can be supportive of the bone. So, if we're reducing weight and not supporting the muscle, that can really accelerate that bone loss and fractures and women, elderly women falling and getting bone fractures or hip, what am I trying to say, breaking a hip. It's very detrimental to her longevity and her quality of life. So it's really, really important. And that's where we want to be doing like a DEXA scan to make sure that we are checking our bone density and then supporting that. And it's, of course, the weight loss is a good thing. So we want to just make sure that we're supporting that muscle, like the things that we just talked about, resistance training as a non-negotiable, and ideally HRT if that's appropriate for that woman.
Mhm. And for the community, right, depending on who your doctor is, if you have one or primary care physician, some of them may be ordering a DEXA scan when you hit a certain age. But how would you advise women to, one, keep an eye out for this, right? You can't see your bones. So, kind of what things to look out for, and then how to advocate for themselves at the doctor's office.
Yeah, I mean, there isn't even a whole lot you can look out for. If you are noticing that you're breaking bones very easily, then that's a red flag right away. If I would say, even if one bone, if you easily break a bone, make sure that the doctor is ordering that DEXA scan. Don't let it go. And really, anyone over 40 should be starting to do these at least a couple, every couple of years. You can do it on your own too. You can order it yourself. But most of the time, if you ask the doctor, they will order that for you, in my experience. So
Okay, thank you. Kind of shifting to the mood aspect and symptoms that people experience throughout menopause, right? Mood changes like depression and anxiety, even sleep quality can be really affected. Can you
yes.
talk a little bit about, what hormones are implicated in that and if the GLP signaling in the brain is impacting that at all?
Yeah, that's another interesting convergence. So, estrogen we know is profoundly neuroprotective. We know that it supports the cerebral blood flow, it supports the neuroplasticity, and it also regulates the neurotransmitters that are involved in like memory and mood. So, serotonin, dopamine. So, very critical for brain function and very well supported. And then we have GLPs, which is more emerging, but we're seeing very clear signals that, going back and looking at these trials where people obese, people who are obese were put on GLP receptor agonists and looking at the Alzheimer's disease risk and seeing that that's being mitigated quite significantly. So this early research looks like it's reducing neural inflammation and reducing amyloid accumulation, which is the precursor to Alzheimer's, and it's also involved in, with the insulin sensitivity, like they call it Alzheimer's disease, type 3 diabetes because of that insulin component. So very interesting mechanistically, and we're seeing the strong signals in the clinical data so far. Now, they have tried to reverse Alzheimer's with GLP-1s. That doesn't seem to be working. It's more of a preventative measure. But any woman who is either experiencing neurocognitive decline, poor word recall, brain fog, mood instability, or if they have a family history, I would take this very seriously, this conversation around estrogen and maybe microdosing a GLP as a preventative measure. I think that is worth having that discussion with your provider for sure.
Mhm. The hormone landscape has been changing so much, even just this year with the FDA removing the boxed warning on hormone therapy. And if we kind of like go back 30 years, maybe let's say the 1990s, where hormones were being regularly prescribed kind of as preventative medicine for women, do you see that shift happening again, that more doctors are going to look at hormone therapy as preventative or just for women who are really experiencing symptoms that are affecting their daily life?
I hope so. I mean, it seems like they're not all doctors are on board yet, for sure. And the women I talk to, they're still, that's part of my role is I to help them to advocate for themselves and just learn this piece of it so that they can take that to their doctor. And I think really that's where it's going to change is women have to learn this information and be the advocate for their own health. The doctors, sometimes they're just busy and they don't keep up with the literature, or they don't have a lot of time unless you're paying out of pocket. So if you want to stay with the primary care, you really kind of have to bring this information to them and present it that way. And, if they don't listen, you can always find another doctor. That's an option.
Yeah, it's one of the missions, I guess, bringing this into this telehealth model is like giving access to as many people as we can who maybe normally wouldn't have it through primary care provider, and also training the physicians to be up to date on the newest literature. We were
Yes.
just talking before this call that, just because a scientific study is published doesn't mean that it's going to be widely adopted, by the community, and especially for the general public who may not have science knowledge. How are they supposed to understand the changes when they come out? Do you have any
Exactly.
resources you go to for these things?
Um, the Menopausal Society, they have a good resource there. I mean, I follow, there's a couple of women that are doing this, talking about it online. I would say Dr. Mary Claire Haver, um, Dr. Amy B. Killen, and a couple others that I'm not thinking of the names right now. But yeah, I think the resources are out there. If you look, you don't have to look that hard. They are out there nowadays.
It's great to know. Kind of going back, I'm seeing some questions in the chat specifically around that 10-year window. Kind of want
Yes.
to demystify it. There's a lot of talk about that. And currently with LAMD, right, we're kind of looking at this 10-year window of when the last period was and kind of being an optimal time to start hormone therapy. But that doesn't mean that, right, older women would not benefit from hormone therapy. So can you talk a little bit about that hypothesis and then also your belief on it and treating women?
Yeah, it's just the optimal time frame because that's when we think that the receptors are going to stay they're not too far gone. They're still kind of active and able to be, I don't know, resuscitated in a sense. So that's the ideal window is within 10 years of menopause. And I would say the earlier that you start, the better. Of course, there's women that have that window is passed, and tell them that you can still get symptom relief from, and that you could still have benefits of adding estrogen. It's just, it might not be as good as starting earlier, unfortunately. We wish we had known this information sooner, but for those of us that are kind of still in the earlier stages, you definitely want to support that ideally within that window. Earlier, better. You can even start before menopause. It doesn't have to wait until after menopause. I know Ellie's kind of working on bringing that treatment to the public, but in the meantime, there's other ways to access that care. Um, but yeah, I definitely don't think that there's no benefit for women if you wait past 10 years. I think you can still benefit from it. And I would definitely have that discussion with your doctor.
I'm seeing this, someone talking about there's different forms of estradiol. There is many, and LAMD currently offers a capsule, which is kind of a systemic, goes around the body. We have a body cream, that's also systemically absorbed throughout the body. There's also a local estradiol vaginal cream, which would be working differently. You can take both forms, right? Either the capsule and
Mhm.
vaginal cream together. Could you talk a little bit about the different forms? There's patches, pellets, so much. And do you have a
Yeah.
go-to, or is it kind of patient by patient that you're assessing this?
Yeah, it's going to vary from person to person. And the first thing I'll say is if at first you don't succeed, don't give up. Sometimes it's a process. But to talk about the different routes, so you have anything that's the oral, so the oral, let's talk about that first. That one, obviously you swallow it. It goes through first pass metabolism in the liver before it gets to the systemic circulation. So that can increase the risk for people that have a high risk of clotting, and it may increase triglycerides more so than the transdermal. So that's just a conversation with your doctor. If you're not a high risk, you can certainly, that's an option. The transdermal is any form that anything else, basically the cream, the patch, the gel, and even the pellets are considered transdermal. And that goes directly into the bloodstream and it avoids that first pass liver processing. So that can have a better profile for cardiovascular and clotting risk profile. But they both have pros and cons. Like the transdermal, I think, is variable. So some people don't absorb it very well. So that's where you want to make sure your symptoms are resolved. And if you have blood work, you want to make sure you're in the optimal range, but also have symptom resolution because a lot of times the doctor will just see, oh, you're normal, but the woman's over here complaining of brain fog and fatigue and night sweats. And so you need to look at both and ideally symptoms over blood work. I would say if you were going to choose one or the other, I would go with the symptoms. But it varies. I mean, I personally didn't do really well with the patch, so I switched to oral and I'm having better results there. So I think, again, just kind of test it out for yourself and work with your doctor to see what's the best for you.
It can take a while for the body to kind of start noticing effects.
Yes.
So even I'm thinking kind of this 2-month period where you give it a trial. Do you kind of recommend people to look out for this, kind of analyze their side effects for a certain time period, and then when is it, when do I need a change? When would you kind of flag that?
Yeah, typically 6 to 12 weeks to really give it a chance to do its job and really work. And also depends on how far, you are into the process. If you're starting earlier, maybe you're keeping the symptoms at bay. But the other thing is, if you're starting in perimenopause and as you go through further into that process, your symptoms can change and you might need a higher dose. You might need to adjust dosing. So it's never like a one and done with hormones. It's a constant evolution. And keeping track of your symptoms, I think, is critical. Like just keep a little journal or write it down on your phone. And that helps too, because then when you go to your doctor, you can say, like, no, this is what I'm experiencing and really advocate. Because a lot of times people are getting dismissed and, you want to have all the tools in your back pocket.
Definitely. And just a little background for the LEMD program. About 2 months in, patients will kind of have an optional reassessment period where they'd be able to, indicate symptom severity. How are these things being managed and side effect profile to kind of determine, whether changes need to be made to either medication strength or, the whole package of medications you are on. It's just very nuanced. And getting into that, I want to talk about lab work because it's a hot topic. Labs, can really help personalize and tailor treatment, but right now, the American College of Obstetrics and Gynecology, the Menopausal Society, and some other organizations, they're all in agreement that menopause is kind of subjectively diagnosed based on symptoms and intake. Can you talk about that? Why lab work isn't necessary for that diagnosis, and maybe, how people can understand their bodies in that way.
Yeah, it's helpful to have. I like to see the lab work, but it's not the definitive factor. The symptoms drive the treatment for sure. With a good provider, the symptoms will definitely drive that because let's look at estrogen, for example. Like the range is from 50 to 150. That's kind of the optimal range. But a woman could be in the low 50s and still having symptoms. So technically on paper, she's normal. But if she's still suffering, we have receptors, we have different genetics, and maybe our receptors aren't as good at taking up estrogen. So, yeah, you could have high levels, but your body's not absorbing it as well as somebody else. So, it really needs to be individualized and based more on the symptoms. And a lot of like if you go to a specialty clinic, they're just driving it based on symptoms more so.
Definitely. It's also in the past have been a conversation now. It's difficult to track female hormones because
True.
they're fluctuating so much and throughout the day. But when you hit menopause, you kind of get this rapid decrease of estrogen and progesterone in the body. So it's more stable than in perimenopause when your symptoms are going this
Hmm.
way. Can you talk a little bit about like if a postmenopausal woman did get lab work, what time of day, or would you trust those results that were coming in? Would it be a blood test, a urine test?
I think the blood test is the best. In I don't have a vast experience with this, but I think the blood test is probably a better option. And it is going to depend. I think what you need to take into consideration is like if, let's say, you're taking progesterone and you took it the night before, the timing of that test is going to dictate what that lab value looks like. So again, it's more symptom based than that absolute lab number because that can vary. And just keeping in mind, like just to tell your provider like when you took your medicine, or maybe you didn't take it since 24 hours if it was your estrogen, you woke up early and you didn't take it, so it can be all over the place, even if you're on hormone treatment. And that's another reason why it's good to just go with the symptoms.
Kind of going through some of these questions, someone saying, what if they're on transdermal estrogen and have kind of some side effects like breast
Mm.
tenderness? Um, do you think, I don't know if you know this, if they were to take the capsule, would those be mitigated? Would it be worth it to look at another form?
Yeah, breast tenderness is a sign that the estrogen is too high, and that can be, again, if it's fluctuating, you're still in perimenopause, then it's tough because a lot of times they'll put you on a lower dose because you are still fluctuating. But any type of breakthrough bleeding or breast tenderness is usually a sign that that estrogen level is too high. So you might want to adjust that down. You could change it to a different form, but I would most likely say that it's working too well for you.
Yeah, and maybe we'll kind of touch on the estradiol vaginal cream and kind of those
Yes.
genital and urinary symptoms. Some women experience them, some don't. Is it true that either way, when they age, the tissue is thinning down there and may benefit from protection?
Yeah, honestly, this is one of the most universal symptoms that women get, and it's not really talked about. I'm not sure why. And unlike hot flashes that are going to resolve as we go through menopause, this actually gets worse without treatment. So, the vaginal tissue, the urethral tissue, the pelvic floor, they all have estrogen receptors and require estrogen for their function. So when estrogen declines, that tissue is going to get thinner. It's losing elasticity, it's losing the pH balance, and that can lead to, dryness and UTIs and painful intercourse and even urinary frequency and incontinence. So a lot things that a lot of women suffer from, and even, especially older women in nursing homes, is actually the UTIs is like one of the top reasons for medical care in that population. And it can actually lead to like sepsis and just, it can very quickly go south. And this is something very easy to treat with this vaginal estrogen. It's not systemic, so it's very safe even for women that are, had a hormone positive cancer. It's safe for almost everyone because it stays locally and it just works on the local tissues, and it's going to really help with unnecessary suffering, and it's usually very inexpensive too. So something that every woman could benefit from.
Right, to see a question coming, can it be rejuvenated and recoverable? It's exactly what the treatment is kind of helping to support the tissue lining and
Yes.
reduce those symptoms. And it also brings, why don't women bring this up and talk about something that comes to my mind, maybe just embarrassment or not wanting to
Yeah.
discuss more private matters. And it makes me think about hormone replacement therapy, on the time scale of when the WHO came out with that study in the early 2000s, a lot of women were too scared to even go to the doctor to talk about this, right? They didn't want hormone therapy. I mean, a lot of the doctors didn't want to prescribe it. And I think that could be such a superpower for the community, knowing that you all, are a network of people and can be an open space to allow these conversations to happen.
hmm Yeah, and it's something that just progressively declines. Like it's a slow decline, so you almost don't notice it until you're like, wait a minute, all this is actually related to estrogen, and it's eye-opening for sure.
Yeah, I'm just looking at some of the questions. I know we covered labs. So currently labs are not required to diagnose, menopause or postmenopause, but we are working at LAMD. We think personalization is very important and tracking also is a key part of that. So labs and expansion into hormones is in the works. I promise you all, just starting with this community. I was thinking kind of how GLPs and the emerging research on like its longevity benefits,
Mhm.
and will hormones also kind of have that longevity piece in time?
Yeah, I mean, I think they're both very tied into the longevity piece. When you have, well, with GLPs, like we're definitely seeing a lot of signals that it's, not reversing, sorry, risk mitigation as far as heart disease, neurodegeneration, liver, kidney, even cancer. So there's definitely some potential longevity benefits, and just lowering that overall, first of all, the visceral fat, because you're losing fat overall, so you're lowering your inflammation. That inflammation is tied into all those diseases. And then you have I'm gonna lost my train of thought, but um, And the insulin, restoring insulin sensitivity, which is something that declines with age as well. And then estrogen is kind of covering some of those same aspects where like it works on inflammation, it works on preserving muscle, bone, heart health, brain health. So we're really, it's the foundation. And I think those two aspects of longevity are really critical to any woman who's, wants to live a long, healthy life, as we all do. So very important part of the conversation for anyone focused on longevity.
Yes, we always say that inflammation is a driver of aging, and we know that GLPs are helping to, as well as a lot of our other peptide offerings.
Mhm.
How does estrogen influence inflammation in the body? Is there a specific pathway, or is it kind of all over?
Yeah, it's mainly through the visceral fat. When we have estrogen at optimal levels, our fat gets distributed to the subcutaneous, like normal, kind of where we think of in women, hips and thighs. And then after we lose estrogen, that's when you start seeing the belly fat and kind of. I hear women all the time, like, where did this come from? What's going on? I'm doing the same exercise. I'm doing the same. I'm always eating healthy. Why am I getting this belly fat? And that's estrogen. It's driving that visceral fat. And visceral fat is really like an inflammatory organ in a sense. And it can have these systemic effects, not just disease risk, but it can actually cause that muscle loss to be worse. It can raise inflammation, it can raise cortisol and just kind of wreak havoc in the body. So treating that as, a very critical aspect of our aging biology is really important.
I know that you're a proponent of kind of starting slow and trying out kind of one thing, seeing how it works. For someone who, let's say, they're in this stage of their life around age 60, they're on GLPs and they've kind of hit this weight loss plateau. Would you have them, look at their hormones first? Would you look at their insulin sensitivity? How would you kind of address cases like that?
Yeah, if they're already on a GLP, more than likely it's probably a hormonal issue that's causing that. And so addressing that first and foremost, you can look at labs, but if she has symptoms, it could, like you said, it could just treat based on the symptoms. Um, but estrogen is really going to be that foundation that's kind of also restoring that insulin sensitivity and lowering inflammation and helping with that muscle and all the things on top of the GLP. So it's really setting up the environment for the GLP-1 to work better. It's just going to have a better signaling environment. So they're kind of helping each other.
A lot of doctors believe, the starting low, go slow, kind of mitigate side effects and see, is the body responding at the lowest possible dose? What are your thoughts around that, especially with hormone therapy, right? There's so many different strengths available. And at least with LEMD's program, most patients would start on the lowest strength, which for estradiol would be zero point 0.5 milligrams, and then kind of see how they're doing. Do you do you have any thoughts on this approach and kind of for someone who would use hormones for a long time in their life, would they take the higher dose and stay on it?
I mean, you would want to start low for sure because you never know. I mean, everybody's going to be a little bit different and you don't necessarily need to give it a sledgehammer if a little dose will help, but I would make sure that she's getting symptom resolution. So again, if you start on the low dose and you wait 8 to 12 weeks and you're not getting that resolution to the full extent, like you're still having night sweats or brain fog or any of those issues, then you would increase the dose. And I know Ellie has the check-ins, so that's really good and ideal. And then you can kind of just keep going with that if until you get to that point where you feel good and you feel like everything's optimized.
Hmm. Definitely. There's quite a few, right, places you can get hormones and even companies out there that have their own hormone programs. And I know I've talked to a lot of doctors and all their practices are different, right? Some women may get an estradiol patch and they won't see their doctor for a year because they're
Mhm.
doing well. And that's why we wanted to kind of have this optional check-in, right? If you're doing fine, we don't want to bother you and have you answer all of these questions. But I think it is really important to have regular follow-up, especially, let's say, in the first 4 months of treatment, until someone is stable.
For sure. Yeah.
I'm just gonna, before we wrap up, try to address some of these questions. We have bioidentical hormone replacement. Might be an interesting topic to cover. And what does bioidentical mean? What is synthetic, and what's the best route?
Yeah, bioidentical just means that it's the same form that your ovaries make. So it's identical essentially to what your body is used to. And with like progesterone in particular, the micronized progesterone, that's like the bioidentical form that your ovaries make, and it actually metabolizes into a compound called allopregnanolone. And that is what works on the GABA system, which is your brain's calming neurotransmitter. So that has the sedative effect, the anti-anxiety that helps support sleep. So all the benefits that we expect from progesterone are tied into that. Whereas the synthetic ones, we're talking like the progestins. This was what was done in that WHI study that kind of flagged the cancer risk, but this was a synthetic form and it doesn't metabolize into the allopregnanolone. So it doesn't even have any of those impacts on GABA that we see from the natural form, the bioidentical form. So definitely has a better activation in the body and more, natural response, if you will.
Mhm. And now that it's kind of widely available, like 30, 40 years ago when the synthetic forms were more common, and even in that study we're talking about with the WHI, it could have been tied to the form of progesterone that was being used. But now that there is technology that's able to make these micronized powders, which is really finely, finely ground up, and also make it identical to exactly what your body is producing, I think the benefits and effects of that are really great. And all of our compounded formulas are using bioidentical and also micronized powders when being formulated. So yes, everyone there. Okay, so as we kind of come to a close here, Dr. Sawicki, do you have any closing thoughts that you want to share about either hormone replacement therapy and GLPs with the community?
Yeah, I just want everyone to understand that the body is not separate. Like everything, like the way our medical system works is we have, gynecology and then we have endocrinology and primary care, and they're all separate and they're all doing their own thing. But that's not how our biology works. Everything is interconnected and everything's working together. And we have multi-systems. Like you see now that estrogen has receptors all throughout the body, GLPs have receptors all throughout the body. And so it's not just a single treatment that's, like a drug focusing on one single thing. It's having these multi system effects. And when we look at, precision medicine and health span and longevity, we really want to be thinking about the body in, restoring our biology. That's how I think of it, as restoring what's natural, restoring our natural biology and our signaling. So that to me is how we practice smarter medicine in the future, is really integrating all these things.
Really love that. I always thought in school when I'd watch the animations inside the cell, it always looked like an orchestra to me. I mean, there's so many moving pieces, and each one of them is integral to the other. So thank you for giving that kind of visualization for everyone and laying out what the vision is here of increasing health span. And by doing that, we need to address, all organ systems and symptoms. And so that is the goal with LEMD. Thank you, everyone, for tuning in. And thank you, Dr. Sawicki. Where can we find you on social media to learn more if we wanted to get connected?
Yes, I'm all over. My Instagram is drchristy.sawicki. I'm on Substack. I have my website is longevitywithchristy.com. So you can find me there and happy to answer questions.
Great. Well, thank you, everyone, so much. If someone invited you here tonight, please don't forget to reach out and just say thank you or share a conversation about what you learned. I hope everyone has a wonderful rest of the week. All right. Bye.